So welcome back. We left off with talking about how bugs develop their resistance, but there are really various factors that contribute to the emergence of this resistance. It's not simply overprescribing or doctors or providers, mid-level providers that are being weak and giving in to the patient who insists that they have an antibiotic prescribed to them. There's really not a lot of good rapid diagnostic testing tools, so empiric therapy is sometimes is required. And the other thing that happens is that there are patients out there, believe it or not, that don't take the entire round of the antibiotic, or they take it inappropriately or indiscriminately, and therefore the bug builds up a resistance because it's never completely killed. Now, when we move out of the spectrum of thinking about superinfections, we also get things like pseudomembranous colitis. You'll recognize this as our Clostridium difficile colitis. And what happens here is that there's this disruption of the normal healthy bacteria in the colon. That has occurred often because of antibiotics. C. difficile can be transmitted from person to person by spores, and it can cause very severe damage to the colon. Patients with this condition can die because of the loss of fluid, so fluid and electrolyte imbalance. And there's also, with antibiotic therapy, the risk of secondary infection, particularly if we're using a narrow spectrum antibiotic and then the body's defenses are weakened, so we can have another infection. Frequently we'll see that as like a yeast infection will show up. We talked about resistance, food-drug interactions, lots of food-drug interactions with our antibiotics. We'll talk a little bit about some of those when we get into the specific classes. There are host factors that need to be taken into consideration. For example, our geriatric patients, they're at a considerably increased risk of infection, and when they do get infections, they're often more serious. Because they have a low body mass frequently, they may need that lower dose. So they're particularly susceptible to the ototoxic effects of the aminoglycosides, and that's something that we'll talk about when we talk about that particular drug or that class. Then our pediatric patients are in increased risk for infection because their immune systems are not necessarily mature. They're also a greater risk for toxicity because until their renal or their hepatic function is adequate. We don't give tetracyclines to this population because the tetracycline it binds to the teeth and discolors tooth enamel even if it's given when the teeth are developing, and that can result tetracyclines can also result in bone growth retardation. The fluoroquinolones will affect growth of cartilage if they're given to when the child is developing bone. So there's host factors that have to be taken into consideration. And of course, there are allergic reactions because antibiotics work in the way that they do, and because they have been given frequently, then we see allergic reactions. We'll see them across classes and across the classes, particularly when they have generations. Not always, but it's possible. Important that we keep that up to date on the patient's chart. So in the antibiotics classes, when we look at them, we see the sulfonamides, the penicillins, the cephalosporins, the macrolides, the quinolones, aminoglycosides, and tetracyclines. And we're going to touch on these a little bit of each of them in more detail. Our antibiotic therapy overall cell or mechanisms of action is that they interfere with that cell wall synthesis, and they interfere with the protein synthesis. So that interferes with the DNA replication. They act as a metabolite to disrupt these critical metabolic reactions inside the bacterial cell. So we can get different actions, the bactericidal, which means that it kills the bacteria, or the bacteriostatic, meaning that it inhibits the growth of the bacteria. And if we look at these, the bacteriostatics arrest that microbial growth and the replication, so it limits the spread of the infection, while the host immune system then naturally eliminates the pathogen. But if the therapy ends before the immune system is completely eliminating the organism, then we can have a second cycle of infection that begins. Whereas with the bactericidal, the ones that kill the bacteria, that leads to a directly reduced total number of the visible pathogens, or the pathogens within the host. So bactericidal agents are actually preferred for patients when they have any neutropenia, because when you have an individual that has a compromised immune system, they can't eliminate those remaining bacteria. So bacteriostatic is not as good a choice for them. When we have any life-threatening infections like an endocarditis or a meningitis, those are treated with bactericidal antibiotics. So let's start into our classes here. Sulfonamides. This is one of the first groups of antibiotics. When this is given, it's often combined with another antibiotic. So, for example, sulfamethoxyl is combined with trimethoprim, and the trimethoprim is a non-sulfonamide antibiotic. You probably recognize this as Bactrim or Septra. So you'll see it abbreviated. It's pretty commonly used in clinical practice. It's bacteriostatic in its action, and it prevents the synthesis of the folic acid required for the synthesis of the purines and the nucleic acid. And so the bacteria fail to grow and divide. We'll see this used commonly, but it doesn't affect the human cells or certain bacteria because they can use a preformed folic acid. So the sulfonamides only affect organisms that synthesize their own folic acid. So it's effective against both gram-positive and gram-negative bacteria. We'll see it used for the treatment of UTIs caused by the susceptible strains of the E. coli or the nocardiosis. With the trimethoprim, that's a dihydrofolate reductase inhibitor. So we sometimes see the medication used for pneumocystis jirovecii. God, I needed a drink of water there. And so the pneumocystis jirovecii pneumonia, which is a common opportunistic infection in patients with AIDS. We'll see it used in chronic UTIs, our GI infections, shigellosis, non-typical or non-typhoid salmonella. We sometimes still see it used in acute gonococcal uritis. And when we look at these infections here, we can see that we use it in Staphylococcus infections outpatient because there's a high rate of the community-acquired MRSA. So some of the side effects or adverse effects that we'll see there include in the blood hemolytic and aplastic anemia and agranulocytosis, thrombocytopenia. We will see integumentary-wise photosensitivity and exfoliative dermatitis or Stevens-Johnson syndrome, epidermal necrolysis. We might see nausea, vomiting, diarrhea, pancreatitis, hepatotoxicity, convulsions, crystalluria. This can be minimized if we have good hydration in the patient and alkalinization of the urine. So that's one that we can try to stave off. We sometimes see connectorus if it's given to a newborn. So that helps to eliminate when we don't have the crystalluria, the toxic nephrosis, or decrease it. We can get headache. Peripherally, you'll see neuritis, urticaria, and cough. If the sulfonamide is given with the trimethoprim, we might see a megablastic anemia, a leukopenia, or granulocytopenia because those are relative to then a folate deficiency. So we've heard about the beta-lactam a little bit. Our beta-lactam antibiotics are penicillins, our cephalosporins, our carbamazepines, and our monobactams. So why are they called beta-lactam antibiotics? Well, resistance can occur to penicillin primarily through this formation of the beta-lactamases. They've also, you will hear them referred to as penicillinases. And what happens is that the structures of penicillins and other beta-lactam antibiotics, the cephalosporins, the carbamazepines, and the monobactams, have in common this beta-lactam ring. And you can see that, this ring that has occurred here. And after years of exposure to these antibiotics, a large number of the bacterial organisms have developed this resistance by producing this enzyme. This enzyme is called the beta-lactamase. And what it does is it hydrolyzes the beta-lactam ring. So it just eliminates this ring, and then the antibiotic itself is rendered inactive. It's ineffective. So we developed some beta-lactamase inhibitors, clovulinate, sulbactam, and tazobactam, to address the problem, but those don't have any antibacterial activity of their own. What they do is they just inhibit the beta-lactamase from breaking down this beta-lactam ring. So we have our natural penicillins, our penicillin-resistant penicillin, or penicillinase-resistant penicillins, our aminopenicillins, and our extended spectrum penicillins. Our natural penicillins are penicillin G and penicillin V. They're generally active against non-penicillinase-producing staphylococci and streptococci, most of our gram-positive organisms. They're active against some of the gram-negative organisms and against most of our anaerobic bacteria. Our penicillinase-resistant drugs are nafcillin, cloxacillin, oxacillin, dicloxacillin. These are active against our penicillinase-producing staphylococci and some of the streptococci. Our aminopenicillins, that's our amoxicillin and ampicillin, they're active against the non-penicillinase producing staphylococci, some of the streptococci, plus some of the gram-negative and the anaerobic bacteria. And the addition of a beta-lactam product, which we will see with our amoxicillin, right? We have the coguvinate added, gives us increases the spectrum so that it will include more gram-positive and gram-negative bacteria and the anaerobes. When we have the combination of the amoxicillin and the clovulinate, it's very commonly used, especially in children. It covers our Staphylococcus aureus, our Moraxicillin caerelis, our H. influenza, our Haemophilus influenza, Salmonella, and Shigella. That you will recognize as augmentin. Our extended spectrum drugs, extended spectrum penicillins, are carbapenicillin, piperacillin, and ticaracillin. So those have extended or increased, rather, the penicillin's activity against gram-negative and anaerobic bacteria. So all these penicillins enter the bacteria via the cell wall,